welcome to another session of the ISN Virtual World Congress of Nephrology. This session is a discussion with KDIGO. KDIGO, Kidney Disease Improving Global Outcome, is a worldwide operating, actually Belgium-based foundation, but bringing us beautiful guidelines for the care of our patients. The topic of today is individual optimization of management of CKD patients with diabetes and cardiovascular disease comorbidities. We have here three worldwide renowned speakers here. Actually, they are members of the working group of the KDIGO guidelines on diabetes management in CKD. And we have three sessions now. Before I introduce the three speakers, I would encourage you to type in your questions into Slido. This is a tool where I can see your question, where we can discuss them during our 18-minute at the end of the presentations. I would also like to invite you at the end to a topical networking session. It's in another virtual room. At the end of this session, you will see an orange button. When you click the button, you can go and you will be driven to the other virtual room, and we can have this topical network session around tables where the speakers are hosting you. So now I think we have, let's not go in order of the speakers, but let's start with the introduction of Erin Mikos. She is an associate professor of medicine at the Division of Cardiology at Johns Hopkins University in Baltimore. And I think, Erin, you also have a joint appointment in the Department of Epidemiology at the Bloomberg School of Public Health, and your other directorship of women's cardiovascular health. So we appreciated all your input in the guideline formation. Then we have Hiddo Lambert-Hersping. He is a professor of pharmacology at the University of the Medical Center and University of Groningen. And he is also a professor in clinical trials and personalized medicine, a worldwide renowned clinical trialists at the Department of Clinical Pharmacy and Pharmacology at the university. I think, Hiddo, you also have a joint appointment, a type of visiting professorship at the University of Sydney, New South Wales, or actually in the George Institute, where you function as a clinical trialist. And finally, we have Professor Peter Rossing, a professor in the diabetes endocrinology and actually diabetic angiography at the University of Copenhagen in Denmark. Peter, you are a renowned clinical researcher. You study complication of diabetes. You are the co-chair of the KDIGO guidelines. And I think also a very prominent chief physician at the worldwide renowned Steno Diabetes Center, and you have your research team at this center. So I think, again, a question in Slido, and don't forget the topical network session at the end. And I think we can start with a discussion with KDIGO about the individual's optimization of management and care for our patients. So please, let's hear first Hiddo.
Ladies and gentlemen, it's my pleasure to participate in this educational symposium at the WCN this year. I'm going to talk about SGLT2 inhibitors and GLP-1 receptor agonists and their mechanism for how these drugs confer kidney protection in patients with type 2 diabetes. My disclosures are listed here on the slide. It is estimated that the number of patients who require kidney replacement therapy will increase in the coming decade. As you can see on the graph on the left, this rise in kidney replacement therapy is particularly seen in Asia, North America, and Latin America. In addition, studies have estimated that the number of patients who die from chronic kidney disease have increased from 2007 to 2017. And this is in contrast to other chronic diseases like COPD or ischemic heart disease, where we have seen a decrease in the mortality rates. And these data illustrate that we need new treatments for patients with chronic kidney disease and type 2 diabetes. In 2015, the first SGLT2 inhibitor outcome trial was published, and that trial demonstrated that the SGLT2 inhibitor empagliflozin significantly reduced the risk of kidney failure. These results were then replicated in 2017 in the CANVAS trial and 2018 in the DECLARE-TIMI trial. Patients enrolled in these three trials were patients with a relatively preserved kidney function at high cardiovascular risk. In 2019, the CREDENCE trial demonstrated that the SGLT2 inhibitor canagliflozin also protects the kidney in patients with diabetes and chronic kidney disease. Since the publication of the EMPA-REG outcome trial, many people have started to speculate about the profound kidney protective effects of SGLT2 inhibitors. And it has been believed, or it is thought, that SGLT2 inhibitors reduce blood pressure and thereby protect the kidney. But others have suggested that SGLT2 inhibitors exert anti-inflammatory and anti-fibrotic effects, which may contribute to kidney protection. And again, others have suggested that reductions in hypoxia in the kidney may also lead to kidney protection. I believe that the reduction in intraglomerular pressure and through tubuloglomerular feedback is an important pathway for kidney protection. And indeed, in a study in patients with type 2 diabetes, it has been shown that SGLT2 inhibitors reduce intraglomerular pressure and glomerular hyperfiltration. In this study, dapagliflozin was compared with gliclazide. And it was demonstrated that after a few weeks of treatment, dapagliflozin causes an acute decline in GFR, which is accompanied by a decline in effective renal plasma flow and a modest reduction in filtration fraction. And this pattern of effects suggests that SGLT2 inhibitors exert beneficial hemodynamic effects, just like ACE inhibitors or angiotensin receptor blockers. And these beneficial hemodynamic effects may translate into long-term kidney protection. What we typically see when we administer an SGLT2 inhibitor to a patient is that during the first weeks of treatment there is an acute reduction in GFR. Again, this is not a structural worsening of kidney function, but reflects the hemodynamic effect. This reduction in GFR is completely reversible after treatment discontinuation. During prolonged treatment, SGLT2 inhibitors preserve kidney function. And this is nicely illustrated in the slide from the CREDENCE trial, where during chronic maintenance treatment, eGFR decline was only minus 1.9 mL per minute per year in the canagliflozin group versus 4.6 mL per minute per year in the placebo group, representing a 60% reduction in the rate of eGFR decline. Now, if this mechanism of hyperfiltration and reducing hyperfiltration is true, it could well be that SGLT2 inhibitors are also beneficial in patients without diabetes, because we know that, for example, obese individuals are often hyperfiltering. Here on the left you see the relationship between body mass index and filtration fraction. And as you can see, with higher body mass index, there's a higher filtration fraction, indicating that these patients are more likely to hyperfiltrate. And indeed, when obese individuals are compared with non-obese individuals, again we see that on the right we see that the filtration fraction and the GFR is higher in obese individuals, indicating hyperfiltration. And thus, if we now treat these patients with an SGLT2 inhibitor, it could well be that the SGLT2 inhibitor protects the kidney in these non-diabetic individuals as well. And indeed, in a long-term outcome trial with dapagliflozin, the DAPA-CKD trial, it was demonstrated that in patients with chronic kidney disease with and without type 2 diabetes, dapagliflozin protects the kidney. The primary outcome in this trial, defined as a 50% eGFR decline, end-stage kidney disease, or renal or cardiovascular death was significantly reduced in patients with and without type 2 diabetes. And the secondary outcomes, a renal-specific outcome, cardiovascular death or heart failure hospitalization, or all-cause mortality, were all reduced both in patients with and without type 2 diabetes and chronic kidney disease. This is not the only trial that suggests that SGLT2 inhibitors are kidney protective in patients with and without type 2 diabetes. Last year, the EMPEROR trial, which was a clinical trial in patients with heart failure with and without type 2 diabetes, also demonstrated that the secondary outcome of this trial, a renal endpoint, end-stage kidney disease, or a profound decline in eGFR, was significantly reduced with a hazard ratio of 0.50, and the trial demonstrated that these effects were also consistent in patients with and without type 2 diabetes. Now I'm switching gears and I'm going to talk about GLP-1 receptor agonists. Cardiovascular safety trials with GLP-1 receptor agonists have shown that these drugs may protect the kidney. The slide shown here is a meta-analysis of these safety trials, and the slide demonstrates that GLP-1 receptor agonists reduce the endpoint of a kidney outcome with macroalbuminuria. If we look at the bottom of the forest plot, where the results on worsening of kidney function decline are illustrated, you'll see that GLP-1 receptor agonist can also protect against this endpoint, although the relative risk reduction is no longer statistically significant. However, these trials enrolled patients with type 2 diabetes at high cardiovascular risk, and most of the trials excluded, or there were only few patients with kidney disease. An analysis from the EXCEL trial compared the effect of exenatide with placebo on the kidney endpoint. And in the trial, as shown on the left, the hazard ratio was not statistically significant. Also, the eGFR decline between exenatide and placebo was similar. However, if we look in the trial at patients with higher albuminuria levels, thus patients at higher risk of progression, exenatide slows kidney function decline compared to placebo in these patients with higher albuminuria levels. Thus, perhaps, particularly in patients at highest risk of kidney function decline, GLP-1 receptor agonists may be protective. Well, if that's true, what could be the mechanism of this effect? It is likely that there are indirect and direct effects involved. Indirect effects include improvements in glycemic control, reduction in blood pressure, and reductions in body weight. Direct effects may involve hemodynamic effects or anti-inflammatory effects, reductions in oxidative stress or inhibition of the renin-angiotensin system. A nice analysis from the SUSTAIN-6 trial, which was a clinical trial with semaglutide, looked at these indirect effects. What you see here is the Kaplan-Meier curve for the kidney outcome. The gray line is the placebo line, and the dark blue line is the semaglutide line. If the authors adjusted the treatment effect on the kidney endpoint for differences in blood pressure between semaglutide and placebo, they calculated that 22% of the protective effect of semaglutide was because of the difference in blood pressure. The difference in body weight between semaglutide and placebo did not explain the kidney protective effect as shown in the middle Kaplan-Meier curve, but the difference in HbA1c between semaglutide and placebo explained 26% of the protective effect of semaglutide. Thus, there may be indirect effects of semaglutide that explain the kidney protection. But there may also be direct effects involved. In contrast to SGLT2 inhibitors, however, GLP-1 receptor agonists do not appear to have hemodynamic effects. And this is illustrated in this elegant study comparing liraglutide versus sitagliptin and placebo. You see the eGFR decline and the eGFR data over time in this study of 12 weeks, and there's no difference at any time point between placebo and liraglutide. So there's no acute dip in GFR as we have seen with SGLT2 inhibitors. In this study, GFR was also measured by inulin clearance, and the renal plasma flow was measured. And as you can see at the bottom of the slide, There was no difference between liraglutide and placebo in GFR, effective renal plasma flow, or glomerular pressure, suggesting that these drugs do not exert hemodynamic effects. However, GLP-1 receptor agonists may improve endothelial function. This study comparing exenatide versus placebo showed that exenatide increases resistant hyperemia index. This effect, reflecting an improvement in endothelial function, was consistent regardless of the diabetes duration and appeared to be a direct effect, because when exenatide was co-administered with exendin-9, a GLP-1 receptor antagonist, the effect was no longer present. Now finally, I would like to look at the future. And perhaps for the future we should start combining SGLT2 inhibitors with GLP-1 receptor agonists. Because this recent study from the CANVAS trial demonstrated that in patients who were receiving canagliflozin and GLP-1 receptor agonist at the same time, there was more HbA1c reduction, the orange bar, more blood pressure reduction compared to canagliflozin alone, and more body weight reduction compared to canagliflozin alone or placebo. There was no further reduction in albuminuria, but the enhanced metabolic effects with the combination treatment suggest that perhaps for the future we should combine these drugs because they exert distinct mechanisms of actions on the heart and in particular on the kidney, and thus when we combine the two drugs we may even protect the kidney more. And that brings me to my summary. SGLT2 inhibitors have been demonstrated to reduce the risk of kidney failure in patients with and without type 2 diabetes. These clinical benefits appear to be independent of improvements in glycemic control. Multiple mechanisms may contribute, including reductions in glomerular hyperfiltration that lead to protection in patients with and without type 2 diabetes. GLP-1 receptor agonists may slow progressive kidney function loss, in particular in patients at high risk. These are patients with higher levels of albuminuria. And the mechanisms are largely unknown, but probably include direct and indirect effects. For the future, combination treatment with SGLT2 inhibitors and GLP-1 receptor agonists hold promise for the treatment of diabetic kidney disease. I'd like to thank you for your attention, and I wish you a nice continuation of the conference.
So thank you to Professor Lambers-Hersping for his presentation on the mechanisms of new therapies in type 2 diabetes and chronic kidney disease. My name is Peter Rossing. I'm professor of endocrinology at the University of Copenhagen in Denmark and head of complications research at Steno Diabetes Center Copenhagen. I'm going to talk about kidney benefits associated with the current pharmacotherapies in patients with CKD and diabetes, the first case which will focus on the kidney aspect. First, I'll show you my disclosures. I work with different companies in relation to clinical studies that are relevant for the presentation today. Most of all, I've been part of the KDIGO guideline committee, and that's relevant for the presentation as well today. But first, diabetes is a big problem, and it's a growing problem. Currently, approximately 460 million people around the globe are expected to have diabetes, and then whenever we see updates of these numbers, the figures are just growing. It's expected to be 700 million in 2045, but that's probably an underestimation, and that's not a local problem. It's happening all over the world. And as you also know, as nephrologists, diabetes is the leading cause of kidney failure in almost all countries. So it's a growing problem, and despite our treatments, this is an increasing problem. I'll discuss a case. Daniel, he's a 62-year-old male with type 2 diabetes. He's had type 2 diabetes for 12 years, and he's not very good glycemic control. Hemoglobin A1c of 9.5%, being treated with metformin, DPP-4 inhibitor, and insulin. His blood pressure is not too bad, 138/80, with different agents, including an angiotensin II receptor blocker in maximal dose. Then he is obese, and he used to be a smoker. So in many ways, Daniel is a typical type 2 diabetes patient as we see them in the clinic. I mentioned his hemoglobin A1c 9.5% was not exactly a target, and you can see, well, target should be individualized, and in patients with chronic kidney disease, that's also the case. We need to find a target that's taking comorbidities, risk for hypoglycemia, life expectancy into consideration. But 9.5 is certainly something we need to come back to for Daniel. Another issue was missing, that was his level of kidney function. And that's actually, unfortunately, also a common problem. More than 50% of people with type 2 diabetes and chronic kidney disease are not really diagnosed because people are not screened for chronic kidney disease. So we need to be aware and do regular screening. There are no symptoms in the early phases, so we really need to implement screening for chronic kidney disease in diabetes. And Daniel has a low GFR of 38 milliliters per minute, so in that sense he is definitely suffering from chronic kidney disease in addition to his type 2 diabetes. And as you know, chronic kidney disease increases the risk for heart failure. Heart failure also increases the risk for chronic kidney disease, so in that sense kidney and heart are working together, and that goes for heart failure and kidney disease, both with heart failure with reduced ejection fraction or heart failure with preserved ejection fraction being much more common in patients with chronic kidney disease. With a GFR of 38, Daniel has CKD, but he's also at increased risk for mortality, cardiovascular morbidity, and cardiovascular mortality as shown here. But we also need his albuminuria, and that was missing. But I can tell you it was 400 milligrams per gram when that was tested. So he certainly is a patient with chronic kidney disease in addition to his diabetes. The KDIGO guideline would say, well, for patients with type 2 diabetes and chronic kidney disease, we need to manage lifestyle, meaning exercise, healthy diet, and stop smoking. We need to manage glycemic control, blood pressure, and lipids. And then you should be on a RAS blocker in optimal treatment, optimal dose, and you need to be on an SGLT2 inhibitor, and then consider antiplatelet if that's relevant. And for Daniel, you can see, well, he had stopped smoking and blood pressure was relatively in control, although not fully in control. And his glycemia was not in control. He was on a RAS blocker. He was not on an SGLT2 inhibitor. Why should he be on an SGLT2 inhibitor? That was one of the new things implemented in the guideline. Well, that's because first cardiovascular outcome trials like EMPA-REG, CANVAS, and DECLARE demonstrated that in type 2 diabetes, the SGLT2 inhibitors reduce not only cardiovascular risk, but also renal risk. And in the first dedicated renal outcome trial in kidney disease and diabetes, the CREDENCE trial with canagliflozin, there was a 34% risk reduction. So indeed, we need to consider SGLT2 inhibitors in chronic kidney disease. It's also important that although the SGLT2 inhibitors only work on glucose when you have preserved renal function, they continue to work on protecting the kidney even if you have impaired renal function. And in CREDENCE, the GFR was down to 30 milliliters per minute at inclusion, and still the kidney benefit was preserved. CREDENCE was done in patients with albuminuria above 300 milligrams per gram and GFR from 30 to 90, and there was a 30% reduction in the primary composite outcome, which was a renal outcome of end-stage kidney disease or doubling of serum creatinine. After our KDIGO guideline was issued, the DAPA CKD study also demonstrated that dapagliflozin gave a benefit, and that was in a population with chronic kidney disease, both with and without diabetes, but again, a really impressive effect, even in subjects where GFR was going down to 25 as an inclusion and up to 75, and all had albuminuria above 200. Once you start the SGLT2 inhibitor in a person with kidney disease and diabetes, you need to consider level of glycemic control. Are you at target? And Daniel is not at target, so we can start the SGLT2 inhibitor right away. But if he had been at glycemic target, and if he had had renal function at a level where you actually see a lowering of glycemia when you start the SGLT2 inhibitor, then you should consider, for instance, reducing dose of insulin. But that's not necessary in the case for Daniel. We can just add the SGLT2 inhibitor. And if you look to the treatment algorithm from KDIGO, well, then we should also remember that metformin, which Daniel was treated with, is the first line glucose lowering agent, but has to be adjusted to the level of eGFR. And with an eGFR of 38, we should actually reduce the dose compared to what Daniel was receiving. So he should be reduced in metformin dose, but he should have an SGLT2 inhibitor added to his therapy. And then, as he'll probably not be in glycemic control on this treatment, we need to consider other agents. And GLP-1 receptor agonists are actually the preferred next agent when you are not achieving glycemic target. That is because, well, GLP-1 receptor agonists are potent in reducing glucose, but also because of the cardiovascular benefit. If you look to meta-analysis of GLP-1 receptor agonist trial, or at least for the long-acting GLP-1 receptor agonist, then in the CKD population, there's reduction of major adverse cardiovascular events with the GLP-1 receptor agonists. So they are recommended after metformin and SGLT2. Now, what if you had, in the case of Daniel, not albuminuria of 400 milligrams per gram, but just had normal urinary albumin excretion rate? In that case, the credence or DAPA-CKD studies are not really valid. And that's actually a quite prevalent phenotype, impaired GFR, but normal albumin excretion rate. And we can go into the cardiovascular outcome trials and see that it seems that in these trials, which were not kidney trials, but cardiovascular trials, that there was some benefit also in those with normal albumin excretion rate for the heart as well as for the kidney. But not many patients were relevant for the, you could say, CKD with normal albumin excretion rate. So we need new data. And this is a slide showing the different renal outcome trials, credence and DAPA-CKD, that have been reporting with SGLT2 inhibitors in chronic kidney disease in patients with albuminuria above 200. In those with normal albumin excretion rate, well, the EMPA-KIDNEY trial is ongoing and we don't have the results yet, but the EMPA-KIDNEY trial will include patients with low GFR, but also normal albumin excretion rate. So that will add to the information we already have about patients with elevated albuminuria, where SGLT2 inhibitors have been demonstrated to be beneficial for heart and kidney. And the EMPA-KIDNEY trial is still ongoing. It includes, like DAPA-CKD, both patients with diabetes and without diabetes, but all having chronic kidney disease. But in contrast to the other studies, as mentioned, patients with normal albumin excretion rate but low eGFR are included as well. So to try to sum up, in the case of Daniel, he should focus on lifestyle, he should lose weight, he should of course continue not to smoke, we should adjust his metformin dose and add an SGLT2 inhibitor, and then consider adding GLP-1 receptor agonist, which would help on weight reduction and also be beneficial for his heart in addition to improving glycemia. We can sum it up also saying continue RAS blocking, healthy lifestyle, reduce metformin, and then remember that when we add the SGLT2 inhibitor to Daniel with the low GFR, there will not be an effect on glucose, but there will still be an effect on kidney and cardiovascular protection. And then a GLP-1 receptor agonist is preferred, and then maybe other agents will be needed to control glucose in the case of Daniel, at least if he's not successful on GLP-1, SGLT2, metformin, and we should stop his DPP-4 inhibitor because GLP-1 and DPP-4 is two different incretin agents and they don't give added benefit. So we can stop the DPP-4 as mentioned. Having said so, it's important to remember that we are actually not implementing this yet, if at least we look into measures of quality conducted here from the US, where they looked into a population of type 2 diabetes with cardiovascular disease, and even 4 years after EMPA-REG was presented, only 7% of patients are treated according to guidelines with treatments including GLP-1 or SGLT2 inhibitors, statins, and RAS blocking therapies. So in that sense, we really need to implement this therapy if it should work and give the benefit to our patients that we saw in the outcome trials. And with this, thank you very much. This was the kidney case, and now we'll hear the heart case.
Hi, I'm Dr. Erin Mikos. I'm the Associate Director of Preventive Cardiology at Johns Hopkins University School of Medicine in Baltimore, Maryland. And it's my great honor to be with you all for the special KDIGO session at the World Congress of Nephrology to talk about our Case 2, cardiovascular benefits associated with current pharmacotherapies in patients with CKD and diabetes. So we'll start with a case patient. She's a 52-year-old woman with type 2 diabetes and CKD, no prior cardiovascular disease. So she's a primary prevention patient. She was diagnosed with type 2 diabetes 12 years ago. Her A1C of 8.2 is still poorly controlled, and she's on a high dose of metformin of 1,000 milligrams twice a day. Her eGFR is low at 48, and her urine albumin creatinine ratio is 360, so she has albuminuria. Her blood pressure is 142/94 despite lisinopril and 40 and amlodipine 5 milligrams daily. And despite atorvastatin 20 milligrams, her total cholesterol is 177, HDL of 32, triglycerides 255, and LDL of 94 milligrams per deciliter. She's overweight with a BMI of 38. She's sedentary, non-smoker, but her father had a heart attack at age 48. So she has a lot of cardiovascular risk factors that puts her at high ASCVD risk. Now, in 2020, KDIGO released our clinical practice guidelines on diabetes management in CKD, and it emphasized that patients with diabetes and CKD really need to be treated with a multi-pronged, comprehensive strategy to reduce risk of both kidney disease progression and cardiovascular disease. And this involves antiplatelet therapy, selectively aspirin in some patients that are high vascular risk but low risk for bleeding. Most patients should be treated with RAS blockade and SGLT2 inhibitors, and all patients need risk factor control, including glycemic control, blood pressure control, lipid management, smoking cessation, nutrition, and exercise. Now, I was a co-author on the 2019 ACC/AHA Primary Prevention of Cardiovascular Disease Guidelines, and we highlighted a number of risk-enhancing factors that place a patient into higher risk group, including having a family history of premature cardiac disease like our patient, having metabolic syndrome like our patient, and chronic kidney disease. Now, patients with diabetes are already recommended for a statin, but additionally, there are diabetes-specific risk enhancers that place a patient at even higher risk that would warrant a high-intensity statin. And this includes longer duration of diabetes, more than 10 years for type 2 diabetes like our patient, or 20 years for type 1. Having albuminuria, a low eGFR less than 60, retinopathy, neuropathy, or a low ankle brachial index. Because so clearly our patient falls in this high-risk diabetes category that would warrant a high-intensity statin. And again, our guidelines recommend that for adults over the age of 40 with diabetes, at least a moderate intensity statin, and in patients like our case patient who have multiple risk factors, to prescribe a high-intensity statin to reduce her LDL by 50% or more. So in our patient, we want to focus on all her risk factors. We want to lower her blood glucose. A goal A1C is typically less than 7, or individualized targets based on patients' comorbidities. Patients who have albuminuria should be treated with ACE inhibitors or ARB like our patient. Our patient's blood pressure goal should be less than 130/80. So she has room to go with blood pressure management. As we discussed, she would benefit with increasing her statin dose for a high-intensity statin for a goal LDL less than 70 milligrams per deciliter. Now, additionally, the KDIGO guidelines really emphasizes the importance of lifestyle interventions in patients with diabetes and CKD. So all patients should consume an individualized diet high in vegetables, fruits, whole grains, fibers, legume, plant-based protein, unsaturated fats and nuts, and low in processed meats, refined carbs, and sweetened beverages. And note that this aligns with many other guidelines, including the ACC/AHA cardiology guidelines, as well as many healthy diet patterns like a Mediterranean diet, a DASH diet, or a healthy vegetarian diet. Additionally, the KDIGO guidelines emphasizes the importance of physical activity that we recommend for most patients trying to achieve above 150 minutes a week of moderate to vigorous activity. But really, any activity is better than none, and patients likely benefit additionally from some muscle strengthening activity. Now, when we talk about pharmacological therapy after the lifestyle interventions, we're really talking about starting first line, both metformin and SGLT2 inhibitors if the eGFR is greater than 30. Metformin for glucose control, but SGLT2 inhibitors for organ protection, heart and kidney protection. And then if additional drug therapy is needed for glycemic control, this is guided by patient preferences, comorbidity, cost, eGFR, such as patients who are not candidates because their eGFR is less than 25. If they're not candidates for SGLT2 inhibitors, might be a candidate for these other agents. Now, notably, there's no head-to-head trial with metformin with other diabetes drugs, but if you look at registry data that's propensity matched, such as this data from the VA system, comparing metformin with sulfonylureas, there was a 20% reduction in major adverse cardiovascular events benefiting metformin. So this really should be the first line for glucose control. So that's what we said in our KDIGO clinical practice guidelines, that we recommend treating patients with type 2 diabetes, CKD, eGFR greater than 30 with metformin. And in patients, like our case patients whose eGFR is less than 60, we really need to monitor closely their eGFR and adjust the metformin when our eGFR is less than 45, or some patients between 45 and 60, like our case patient. Now, we're really in an exciting era where we have new drugs that were initially targeted for diabetes management, but now we have learned they have really important benefits beyond their A1C lowering, benefits notably with reductions in major adverse cardiovascular events, reduction in heart failure hospitalizations, and major adverse renal events. And really, what kicked us off on this timeline was the landmark EMPA-REG study in 2015, testing empagliflozin versus placebo in patients with diabetes, of which 11% had diabetic nephropathy. And not only did this study show that the SGLT2 inhibitor was cardiovascularly safe, but had really meaningful cardiovascular benefits with a 14% reduction in major cardiovascular outcomes, a 38% reduction in cardiovascular death, and a 32% reduction in all-cause mortality. And since that time, a number of other SGLT2 inhibitor cardiovascular outcome trials have been completed. And when we look at meta-analyses, we see that across eGFR categories, that patients who have eGFR 60 to 90 or less than 60, the CKD patients, their benefits for heart failure, reduction in heart failure hospitalizations and reduction in major adverse cardiovascular events is even greater than patients whose eGFR is above 90. Now, additionally, if we just look at the CANVAS program, canagliflozin among patients with CKD with eGFR less than 60, we see that for every 1,000 patients with CKD treated with 5 years with canagliflozin, you could reduce 65 cases of a major adverse vascular event and reduce 47 cases of hospitalization with heart failure. You also heard from Dr. Rossing about the reduction in renal outcomes. Now, in a meta-analysis of CKD patients and SGLT2 inhibitors, 27 studies included over 7,000 participants, including the individuals who have an eGFR less than 60. Combining all this data, you see that there's a 19% reduction in major adverse cardiovascular events, a really dramatic 39% reduction in heart failure hospitalizations. And again, you heard about the kidney benefits. But notably, there was no interaction by individual agents, meaning that this is really a class effect. This wasn't really driven by any one SGLT2 inhibitor in particular, and they all seem to be equally beneficial in improving these important heart and kidney outcomes. Now, additionally, higher risk patients seem to benefit even more. So in this analysis from the Canvas canagliflozin program, that if you look across KDIGO a classification of risk, and this risk is characterized by EGFR levels and urine albumin creatinine ratio levels, that higher risk patients, particularly this very high risk group, they derive the most benefit with the most numbers of major adverse cardiovascular events avoided with treating with SGLT2 inhibitors. Credence was a trial that enrolled only CKD patients, and you see that they demonstrated meaningful cardiovascular outcome reduction in this group, as well as improvement in blood pressure and body weight, which would be important for our patient. So looking at the Credence data, the number needed to treat over 2.5 years, you would only need to treat 46 patients with canagliflozin to prevent a heart failure hospitalization and 40 patients to prevent a major adverse cardiovascular event. So incorporating the more recent updated meta-analysis, when you look across a spectrum of cardiorenal metabolic risk, including 71,000 patients in 10 of these major clinical trials, you see that overall that SGLT2 inhibitors reduce cardiovascular death or heart failure hospitalization by 24%. Additionally, across all these studies, you see the reduction in heart failure events about 25 to 30%. That's remarkably consistent. But let's focus just on the CKD group. We have 3 trials now that specifically enrolled only a CKD population: Credence, DAPA, CKD, and SCORED. And among this group, you see similar benefits with a 27% reduction in cardiovascular death or heart failure hospitalization. Looking at absolute risk across all these studies and across a cardiometabolic risk spectrum, clearly the highest risk patients are those who already have HFrEF, heart failure with reduced ejection fraction. And so you get the greatest absolute risk reduction for this group with SGLT2 inhibitors. But notably for albuminuric CKD, the number needed to treat is around 100 to reduce cardiovascular death or heart failure hospitalization. Now let's get back to our case patient. I'm changing it up a little bit, but what if she was a little bit more advanced in her disease spectrum? Despite metformin and being on insulin, her EGFR is now dropped to 24 and a urine albumin creatinine ratio of 1200. So what would we do now in this situation? Well, clearly she's not a candidate anymore for SGLT2 inhibitors, but going to our KDIGO clinical practice guidelines and following this algorithm, certainly she's at high ASCVD risk, and therefore the best agent for her would be a GLP-1 receptor agonist. Now, in meta-analysis of a GLP-1 receptor agonist, we see about a 12% reduction in major adverse cardiovascular events and a 12% reduction in cardiovascular death with GLP-1 receptor agonists. But notably, when we look for MACE, there was no interaction by EGFR status, where individuals with an EGFR less than 60 and above 60 derived similar benefit from GLP-1 receptor agonist therapy. And then looking in another analysis, some earlier studies by CKD levels, that you see similar benefit of a 15% reduction in MACE, both for stages 1 to 2 and 3 to 5 CKD. So in our practice guidelines, we recommended that in patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets despite use of metformin and SGLT2 inhibitors, or who are unable to use these medications, we recommend a long-acting GLP-1 receptor agonist. And notably, Rewind study with dulaglutide studied a predominantly primary prevention population and showed this 12% reduction in MACE. Now, they weren't just a CKD group, But there is a designated trial award specifically looking at dulaglutide and more advanced CKD levels 3 to 4. And we see not only is there safety, but there was a meaningful reduction in progression of kidney disease. And dulaglutide is approved down to an EGFR less than 15. So, looking at our patient now, if her EGFR was 24, again, she needs a multidisciplinary collaboration between primary care, endocrinology, nephrology, cardiology, nutrition, exercise. She needs attention to those lifestyle modifications we reviewed. She needs attention to her cardiovascular risk factors that we reviewed. She should be on kidney protection drugs with a ACE or A or B and a GLP-1 receptor agonist. She's not a candidate for SGLT2 inhibitor, and she needs to be off her metformin now. Her EGFR is too low. But we can initiate GLP-1 receptor agonist. Dulaglutide can be started at 0.75 milligrams once a week, and then we could titrate up to 1.5 once a week. And once we titrate up, then she's at the dose. And notably, we can consider using GLP-1 receptor agonists as her basal regimen. So we may be able to stop her insulin glarginine and just use homolog insulin above at mealtime if her blood sugar is above 150. So I just want to put a plug. I'm a cardiologist, and I've been trying to get my cardiologist colleagues on board with using these agents for their meaningful cardiovascular benefits, because there are much more cardiologists. This is U.S. data, but I think it's probably worldwide. There are more cardiologists than there are endocrinologists and even nephrologists. So we all need to be on board with getting our patients on these best agents to manage their cardiometabolic risk. So in summary, these high-risk patients need a comprehensive approach with lifestyle management using the appropriate anti-glycemic therapies, with first line being SGLT2 inhibitors if their EGFR is appropriate, and then monitoring glycemic targets. And again, we're treating multiple targets using a multi-pronged approach. Thank you for your time, and it was really a pleasure to be with you today.
Thank you all. And last speaker, Erin, very tough, I must say. I think we have to discuss, and your really difficult cases as well. So the question from Slido are coming in, and I just take a couple before I have some comments. And the first one is one I know already, is the combination with ACE and ARBs. In most trials, are SGLT2 inhibitors only effective when given with ACE and ARBs in most trials, or do you think they work also without ACE and ARBs? And I think we can ask KDIGO, about the pharmacologist, about this.
Yes, indeed. They have been used in many patients who were already using an ACE inhibitor or angiotensin receptor blocker, in particular in the clinical trials that were conducted in patients with chronic kidney disease. But we have data from one of the earlier cardiovascular outcome trials, like the EMPA-REC outcome trial and like CANVAS, where there were about 20% of patients who were not using an ACE inhibitor or angiotensin receptor blocker. And if we then look at the subgroups, those with or without an ACE inhibitor or angiotensin receptor blocker, we actually see that the effects are consistent. They are present both in patients with and without using these drugs. So we can recommend them. And the question for me for the future will be, should we consider SGLT2s even before ACE inhibitors or angiotensin receptor blockers? That's a provocative question that requires a dedicated new trial, but I think it's an important question to answer.
I think it's also important in the light that nephrologists or doctors sometimes stop ACE and ARBs, first of all, of the potassium signal, and then when patients drop with their EGFR, they are afraid even, yeah? So it's good that you say that they work in isolation as well as in combination.
Yeah. Yeah.
And if I now approach Erin with a question about approach your epidemiology head, and also ask KDIGO, how many patients do we have in clinical trials so far? I think I have never seen in medicine a field where so many clinical trials have accumulated in a short period of time. And my question is, do you expect any surprise in the future in the light of so many trials? What is your feeling? Are we already done? Should we more promote? Or what do you expect anything what is coming up?
Well, this is great. Well, I'm excited that there is so many cardiovascular trials, outcome trials, because, randomized clinical trials is what shapes guidelines. And so we have a lot of informative information. But I think one of the biggest challenges is making sure that we put guidelines into practice. And you saw the, unfortunate data that many and most appropriate patients for these drugs are not being treated, not being appropriately treated. So I think first we need to implement the guidelines that we already have. But as you and Peter highlighted, there are some areas where there's uncertainty that hopefully future trials will fill in some gaps. I think EMPA kidney will fill in some gaps about patients who don't have reduced eGFR but don't have albuminuria. So I think that more trials will help fill in some of these gaps. But I would put a plug that we really need to get the message out there and implement the data that we already know.
I think it's 70,000, right? 70,000.
Yeah, I did. I did my calculations as well, Christoph, while Erwin was talking. And indeed, I was also around 70,000. And I think we don't have that much evidence ever collected for a specific drug class. And that's why we have to implement these findings. We have the evidence, and it's now the responsibility of physicians, clinicians, policymakers, payers to implement these findings in clinical practice. And I can only echo what Aaron just said. It's unfortunate that we haven't done that yet to the extent that I would have loved to see, but still we can do it in the future. And of course, there are areas for new research, very interesting areas, dedicated subgroup of patients, or even patient populations like kidney transplant patients, in whom we don't have a lot of clinical trials, and these drugs could be extremely useful, in particular SGLT2 inhibitors. They could prevent new onset diabetes in these patients who are at high risk of developing diabetes because of the medication they receive, as well as reducing mortality. But there are many other patient populations that could benefit from these drugs.
Okay, with this initial please, we now go into short questions, short answers, because they accumulate. The questions, and Peter, you are the next. Mustafa Arici from Turkey, Istanbul, is asking, he is seeing a naive patient and he wants to combine at once, and he's afraid of a really dip in eGFR. Are you afraid?
No, I'm not, but it's a good question, and honestly, the studies were done where people were started on ACE and ARB, and then the SGLT2 inhibitors were added on top. But I really think that the small dip we see with the SGLT2 inhibitors reflect the hemodynamic action, we think, but it doesn't reflect a potential concern as we had with RAS blocking agents, where we are concerned of renal artery stenosis or so. So in that sense, it's fine. It doesn't matter, and you can continue. And we can even debate whether we need to measure kidney function after starting up an SGLT2 inhibitor. But if you do the combination together, then I think it's still a good idea, as we recommend when you start up RAS blocking therapy in general. And I think that from a, you could say, psychological perspective, sometimes it's a good idea to make things stepwise, but it's also good to, from the beginning, make it clear to the patient that it's not about one drug, but it's a combination of agents that needs to be added over some next weeks or months. And so it's not kind of felt as a failure if one drug is not sufficient, but make it clear that we have now multiple options that can improve outcome.
Then a question to Erin from the island of Cebu in the Philippines. So Danny Yu is asking, the complex heart failure medication and SGLT2 all in once. I think there is an opinion in the cardiology world. How do you do this?
Yes, well, I'm encouraged by the data from Soloist about starting SGLT2 inhibitors, relatively soon, with acute heart failure hospitalization. We know that in general that patients are more likely to be adherent to medications if you start them in acute settings. And sometimes if you wait to give them in the outpatient setting, they may not ever be implemented. So I think that these medicines should be used in combination. And it seems that the SGLT2 inhibitors benefit equally individuals, with volume overload and without volume overload. And I think sometimes there's some concern that, we have to reduce the diuretic dose with SGLT2 inhibitors, but that doesn't really seem to be the case. If you look across the trials, none of the trials had a protocol where you had to actually reduce the diuretic dose to get the SGLT2 inhibitors on board. And if any case, if the diuretic dose needs to be reduced later, it's likely because the patient's clinically improving from their heart failure, rather than the fact that the SGLT2 inhibitors, interact negatively with loop diuretics. So I really think that, once you stabilize the patient, that trying to get all the patients on board with the appropriate 5 pillars of heart failure therapy relatively soon in their course.
So John McMurray in Circulation recently stated, all in 4 weeks. I think it's tough, yeah, but okay, good. So there is a question maybe for Hido, a safety signal in respect to peripheral artery disease. Did you ever observe something here?
Yeah, there was some concern that people with peripheral artery disease would be at higher risk of safety, and also in respect to the earlier findings from the Canvas trial that looked at amputation. I believe there's a very nice publication from the EMPA-REC outcome trial, and Christoph, you were involved in that, where that showed that actually with empagliflozin, there was no risk even in people with peripheral artery disease, and the same was seen in the DECLARE study. And we don't have that signal also that there may be more safety adverse events in the trials in patients with chronic kidney disease. So I think it's safe to start these drugs in these patients as well.
Then there is a question, maybe this is going into the future because we have no label so far for no diabetes, but we could give an aspect about the future, maybe Peter. Actually, the study has been done by Hido. Adverse effects in general, if you prescribe for reduction for weight, blood pressure, and heart failure. Peter, what do you think first?
Sorry, you're asking for the non-diabetic kidney disease?
Actually, I'm asking for non-diabetic. We are moving out into the future. We cannot do this in the moment.
No,
so,
but as you say, in DAPA CKD that Hido was leading and I was following, we had the pleasure of seeing very, very positive effects, exactly as similar benefit in the non-diabetic chronic kidney disease as in the diabetic kidney disease. And of course, that's being evaluated now by different communities to see if that's something that you would recommend specifically in that population. But it was a population of non-diabetic kidney disease that was larger than most of the previous studies conducted in non-diabetic kidney disease, with very positive findings, both on progression of kidney disease and other endpoints. So in that sense, I think that's something we'll learn much more about and look forward to see in the future, because that's you can say an untapped area where we now have several data in the diabetic kidney disease. Then it seems we are now getting data in non-diabetic kidney disease, and it seems to work. And the side effect profile is just as good or maybe even better than in the diabetic patients.
Yeah. I think there is a question on the prudent time to wait before adding a new agent, because we discussed all in 4 weeks. So actually maybe a question to the pharmacologist. What do you recommend, Hido, when you build up this cascade of heart failure medication and adding one to the next? Is there anything in pharmacology what could be recommended?
Well, the order cannot be recommended because the order is something that we have to investigate, and we can only do the historical order: ACE inhibitors first, then SGLT2 inhibitors, perhaps added GLP-1 receptor agonists even in the future, perhaps in non-diabetic patients. I know it's not studied yet, but I would think that it is even possible. But certainly in diabetes patients, if glycemic hyperglycemia is not controlled. And then we also have for kidney protection finerenone. And when do we add finerenone? And which patients should have SGLT2 and finerenone? Which patient only SGLT2? Which patients only finerenone? We don't know. So there's now, with these drugs that show benefits on endpoints, we suddenly come into a new era of combination treatment for different patient subgroups, and that will be very exciting in the future to investigate.
Okay, I have so many more questions on the plate. Maybe we can discuss them in our virtual room on mechanism of decompression in heart failure, or the real world, or the referral of tough patients, or the lifestyle. I think there is many more to discuss. I think first, this was a great session. I think we had also a good discussion. I thank you for your input. I think that KDIGO deserved this high class because the guideline is just great. And I think we move over to our virtual room, and for the audience, there is an orange button on the bottom. If you press them, you can walk to the room and select the table. So at this point, thank you all, and see you soon. Bye-bye.